Good evening, everyone, and thanks so much for tuning in to our talk. First, I wanted to go over what we mean when we say atrial fibrillation clinic. Atrial fibrillation, as you'll learn tonight, is a very complex arrhythmia, multifaceted. It covers a lot of different aspects of physiology and interacts with a lot of different kinds of illnesses. And it takes a whole team of us to help people through this illness. We work with each person throughout our community to achieve goals of getting their symptoms controlled, keeping them out of the hospital, finding the best treatments to prevent any symptoms they might have from AFib, and importantly, to prevent stroke. And we'll talk about each of those tonight. Atrial fibrillation is seen by many different kinds of doctors: cardiologists, subspecialist cardiologists, people who help us control medication use and thin people's blood to prevent stroke. Neurologists get involved, heart failure doctors, and a variety of nurses, advanced practice practitioners like nurse practitioners and physician's assistants, and surgeons even. And we all work together to help people reach their goals in treating this complex condition. You'll learn tonight about what atrial fibrillation is and all the different medical and procedural ways you can treat atrial fibrillation. What I wanted to also go over, though, is what an individual can do for their atrial fibrillation. Here in Boulder, people are very involved in their healthcare and want to do whatever they can do to help decrease this condition. And so I'm going to go over the evidence supporting what we can do for that. You'll learn a lot of sciencey things tonight, and sometimes that can be completely overwhelming. And hopefully we'll straighten out all the questions that you may have. It's really important in atrial fibrillation to know that there are a lot of things that you can do to improve your atrial fibrillation. Lifestyle measures that I'll talk about improve your freedom from atrial fibrillation, the length of time you can go without having it, and it can also prevent atrial fibrillation from going from what we call paroxysmal, meaning episodes that come and go on their own, to persistent atrial fibrillation, which is where people just stay in atrial fibrillation until medical practitioners intervene on it. In addition, lifestyle measures can make ablation, the best treatment we have for AFib, which we'll talk about tonight, more effective. And furthermore, lifestyle measures can decrease your risk of stroke, which is the worst outcome that people can have from atrial fibrillation. There are a variety of different published papers in the cardiology literature going over what lifestyle medications can do and have proof of their function in treating AFib. This chart goes over a series of different trials that were done and shows that interventions that help people lose weight, and one way we measure that is by making the waist circumference smaller, and losing weight in general, decrease how much AFib people have. In addition, these other trials can show that other interventions, especially weight loss, increases the length of time that people go without having any atrial fibrillation at all. The things that are modifiable, things that you can do for yourself, include your weight and your physical activity, high blood pressure, sleep apnea, the presence of diabetes, high cholesterol, alcohol use, and smoking. Each of those plays a role in the development of AFib, the progression of AFib, and addressing each of those can help control AFib and even reverse it. So as far as diet goes, we know from studies that the standard Western diet increases atrial fibrillation, and it does that through creating inflammation, damage to the blood vessels, and increasing glucose levels in the bloodstream. What I mean by a standard Western diet is one that is unfortunately high in salt, sugar, and fat, processed foods, things that come in packages, and even restaurant foods. In contrast, on the other end of the spectrum, we know that a diet that is very high in whole foods and largely plant-based, improves atrial fibrillation. And it does that through less inflammation, healing blood vessels, regulation of blood sugar, and even reversal of type 2 diabetes, and lowering the amount of fat that's on the surface of the heart. Excess weight itself increases atrial fibrillation. When people carry excess weight, say around their midsection, that correlates very strongly with what we call epicardial adipose, which is fatty tissue that sits on top of the heart. And in fact, it sits right on top of the upper chambers of the heart, which are what involved in atrial fibrillation. Also, excess adipose or excess fat increases other risk factors for both atrial fibrillation itself and for stroke. And these include sleep apnea and high blood pressure. Losing even 10% of excess weight when that might be needed improves atrial fibrillation. So this is a diagram where it says EAT, that stands for epicardial adipose tissue, and that is the yellow kind of stuff that it does play a role in sort of cushioning the blood vessels against the heart, but it has other activities, metabolic activities that are not good for atrial fibrillation. Here is a diagram where, again, the yellow globules sort of there are shown around, sitting on top of the left upper chamber or left atrium. And the thing about this tissue is it's not just fatty tissue that sits there. It's very active. It releases a variety of different inflammatory chemicals that can damage the upper chambers, cause scar in the upper chambers, prevent the fibers that make up the heart muscle to separate and then not beat as effectively, and all this contributes to an increase in atrial fibrillation. So the way I describe that to people is almost like a sponge. This epicardial adipose is filled with these inflammatory chemicals that are sort of dripped like a sponge onto the heart surface. Smoking is also a very significant risk factor for atrial fibrillation, and folks who smoke increase their risk of developing AFib by a factor of 5. Smoking independently of AFib also increases the risk of stroke and directly causes damage to heart cells and the blood vessels, and like we've talked about a few times, increases general inflammation. Alcohol, unfortunately, I have the bad job of describing that even one drink a day, unfortunately, increases the development of atrial fibrillation. Drinking most days of the week increases someone's burden of atrial fibrillation and likelihood of developing it, and multiple studies have shown that. So in folks who really suffer from atrial fibrillation, one, they may notice that even going out and having 1 or 2 glasses of wine with dinner is a trigger for an episode of AFib. But for folks who are happy either way, avoiding alcohol can greatly increase the amount of AFib or even having AFib at all. Exercise is very important, and here in the Boulder area, we're in a unique situation. In many places that I've worked, people rarely exercised, and that is a risk factor for development of atrial fibrillation. Here, often we see the opposite of that. We see people who are pro athletes or former pro athletes who may cycle hundreds of miles a week or run marathons regularly, or in the winter, Nordic ski. And unfortunately, very vigorous, intense exercise, like aggressive cycling, carries an association with development of AFib, as do other endurance exercises like the ones I mentioned. So it turns out for atrial fibrillation itself, between about 150 to 300 minutes, 2.5 to 5 hours a week is the amount of exercise that's the least associated with AFib. So there's this baby bear zone in between no exercise and maybe too much exercise for developing AFib. And this is sort of the curve that we look at, where on the far left of that are folks who are sedentary and may tend to have more obesity, higher blood pressure, diabetes, and on the far right, people who very vigorously exercise. And as the green curve goes up on the left and the red curve goes up on the right, they're the folks who have the most atrial fibrillation. Stress I'm often asked about, and it certainly plays a role in atrial fibrillation, and it creates this vicious cycle. Both physical and emotional stress can trigger atrial fibrillation, and then conversely, when people go into atrial fibrillation, they may not feel palpitations or erratic heartbeat directly, but they can feel like they're under stress or feel anxious, and then that can trigger more atrial fibrillation. Studies have also found that techniques to reduce stress decrease atrial fibrillation. So that includes things like moderate exercise, like walking, hiking, like we're blessed to have so many options here, and various forms of meditation have directly been studied and shown to decrease AFib burden. Sleep is incredibly important for atrial fibrillation. Sleep and all those other lifestyle factors are interconnected. For example, people who sleep the most poorly have highest blood pressures, and then those folks conversely get a lot of atrial fibrillation. The ideal amount of sleep to shoot for AFib and many other health outcomes is about 7 to 8 hours a night. Poor sleep quality, like people who may drink alcohol, especially before bed, carry excess weight and may have sleep apnea, and stress again, those factors all then worsen sleep, and then that can increase AFib. Sleep apnea, as I've mentioned, is a major cause of atrial fibrillation, and in fact, in an AFib clinic, about 85% of people in the AFib clinic may have some degree of sleep apnea. That's around the whole country, we find that to be true. So many times, an AFib doctor may be the first person to screen someone for sleep apnea because finding it and treating it is so important for the control of atrial fibrillation. If people have sleep apnea, but it's not yet diagnosed or treated, and then we as heart rhythm specialists go to treat the AFib, it lowers the success of anything that we do. Makes medicines less successful and makes even our ablation procedures less successful. The treatments for sleep apnea are weight loss if it's needed, and CPAP are both shown to be very helpful for sleep apnea as well as for AFib. This is a very busy slide that just goes to say that modifying all these risk factors, what you eat, how much you exercise, controlling your blood pressure, high cholesterol, alcohol use, smoking, all of those things are things that an individual can target that can help their atrial fibrillation as well as many other health concerns. So in conclusion, there are many options, things that you can do for yourself even without us that can improve your AFib. And the important ones are reaching a weight where it may not be the weight that you're excited about looking for a specific goal for, but if you can get to any weight that has your waist smaller than your hips, that is associated with less AFib. Also, shoot to eat a diet that is very high in whole foods, especially whole plant foods, and conversely low in processed foods. Quit smoking if you smoke, and there's a lot of help out there to do that. Avoid alcohol if you're able. Reduce stress. Consider meditation can be very useful for that. And then engage in moderate exercise, ideally 3 to 5 hours weekly, which is the ideal zone for helping you prevent and treat atrial fibrillation. Having a dog is a great way to get outside. This is my pup, and she gives me a great excuse to walk a couple times a day, and if I don't do that with her, she certainly lets me know. So now we're going to hear from Dr. Lawand, and he's going to talk more about exactly what happens in atrial fibrillation and the 2 different ways we treat it. One is called rate control, which is slowing AFib down when you're in it. And the other is called rhythm control, which is really keeping you from going into AFib and keeping you in normal rhythm as much as possible.
All right. Hello, I'm Dr. Lawand, cardiac electrophysiologist, and I'd like to thank you again for having us here and allowing us to talk about our favorite topic, atrial fibrillation. So we'll cover the basics, talk about some definitions, and talk about how AFib progresses across a timeline. Rhythm control and rate control are the 2 pillars of treating AFib, and we'll talk about each of those approaches. And we'll even touch on some medical management, which includes antiarrhythmic drug therapy, as well as procedures that we do to treat atrial fibrillation. So what is AFib? So here we're looking at the heart beating, and you see that the natural pacemaker of the heart, which is present in the right atrium, allows the heart to beat in a nice, regular, and synchronous manner. And the upper chambers basically is where the impulse starts. And the upper chambers, which are called the atria, support the blood flow going down into the ventricles. And the ventricles are basically doing the lion's share of the pumping and allowing that blood to go into the peripheral organs. Now here what we're looking at is basically disorganized activity in the atria. Normally, obviously, when your heart is beating, you don't have chaotic activity like this. And the electrical rhythm is disorganized. And when that happens, the atria then start to become a problem because they don't allow blood to move to the ventricles in an efficient manner. This is not immediately life-threatening per se. And here what you're seeing is normal rhythm on the left. That's a normal sinus rhythm, EKG. And then on the right, you see the heart rate go fast and irregular. And that is what we call atrial fibrillation. Patients can develop palpitations, a sensation of rapid heart rate, rapid irregular beating in their chest. And what happens is that you get loss of heart efficiency because the atria are not allowing blood to transit in a normal fashion into the ventricles. Heart failure can develop over time, especially if the heart rate is fast for several months or maybe even years. The heart muscle can weaken. Lastly, risk of stroke. This is very important because when blood doesn't move efficiently through the heart, it can actually swirl around. And when it swirls around, you get what we call stasis. And when stasis happens in the heart atria, clots can form. And those clots can actually go to the brain and cause a stroke in people who have AFib with certain risk factors. So what is the timeline of AFib? Typically, AFib develops over years. In the beginning, you have what we call paroxysmal AFib, and it is a progressive disease, unfortunately. And you can go from paroxysmal AFib, where you have AFib only every now and again, to a situation where you get wear and tear of the atria. When the atria are not beating normally during fibrillation, they can develop damage. And that damage can actually further accelerate atrial fibrillation. And if it's not treated early on, AFib can go from being present every now and again to being present all the time. Once AFib is persistent, it becomes very difficult to return to sinus rhythm and stay in sinus rhythm. So what are the risk factors for atrial fibrillation? Structural heart disease. Patients who have a pre-existing diagnosis of heart failure or valvular heart disease or have had a heart attack in the past are at higher risk for developing atrial fibrillation. Other risk factors such as high blood pressure, diabetes, and obstructive sleep apnea are also risk factors for developing AFib, and some of these risk factors also increase the risk of stroke for patients that have atrial fibrillation. Some non-cardiac conditions can actually directly cause atrial fibrillation. A very common one is thyroid disease. Hyperthyroidism can actually directly cause atrial fibrillation. We always check for patients for thyroid disease if they develop AFib. Lung disease and substance abuse can both also directly cause atrial fibrillation. Caffeine, there's a question mark around caffeine because caffeine from non-coffee sources can cause atrial fibrillation. Caffeine in energy drinks can cause AFib and other even more dangerous arrhythmias. But in coffee, caffeine is unlikely to be directly related to atrial fibrillation. It's really the synthetic substances that caffeine is delivered in. Some trauma, sepsis, lung failure, respiratory failure, post-surgery, and electrolyte abnormalities can cause atrial fibrillation. And these are all called reversible causes of AFib. For the most part, if AFib is caused directly by these things, then by reversing and correcting these non-cardiac problems, AFib can be controlled. So we'll touch on rate control and rhythm control. Rate control is an approach to just control the heart rate while in atrial fibrillation. So the goal is not to convert AFib to a normal rhythm. The goal is really just to slow it down, slow down the response of the heart to the atrial fibrillation. It's a pretty straightforward approach to treating AFib. And typically, we use this when AFib is first diagnosed. What we want to do is slow down the heart rate and get patients feeling a little better. Now, some patients are not appropriate for a rhythm control strategy, and those patients could be frail or have other problems that limit our ability to use a rhythm control strategy. It's not very effective, though, in preventing the progression of AFib from paroxysmal to more persistent. The rhythm control strategy is where we as cardiac electrophysiologists mostly come in. We're trying to convert AFib to a normal rhythm. We're trying to prevent AFib from progressing over time. And it also treats the AFib symptoms as well. There are certain things that can be prevented with a rhythm control strategy, including heart failure. There is some data out there that an early rhythm control strategy is associated with a lower risk of stroke. And there are studies out there on heart failure patients that actually show that by treating the AFib early in patients who have heart failure, there is some mortality benefit, reduction of some harder endpoints down the line. Medications can be used. These are antiarrhythmic drugs. And there is the ablation procedure that is the most effective way at treating or at getting rhythm control in patients with atrial fibrillation. Both are designed to suppress the triggers that cause AFib and restore sinus rhythm. So how do we choose between the two approaches, rate control versus rhythm control? We try to do both at the same time. They actually help complete each other's roles. Rhythm control is for patients who are truly symptomatic from their atrial fibrillation. Some symptoms include fatigue, palpitations, lightheadedness, chest pain, or shortness of breath. Early AFib can be treated with this to prevent it from progressing. When rate control isn't working, then we will certainly try to convert the rhythm from AFib to normal rhythm, and especially if AFib is causing heart failure. Rate control really is not able to typically fix the specific symptoms of AFib, especially the palpitations and the lightheadedness. But it can help slow down the heart rate and potentially help the heart from going into heart failure. Patients who have been deemed to be in AFib all the time are patients who have permanent atrial fibrillation. Those patients, there's been a decision made by the treating provider that any more efforts to convert to a normal rhythm are futile, and the next treatment approach would be just to control the heart rate. So what are the options for rhythm control? We have antiarrhythmic drugs. They're not perfect, and most of these drugs have side effects. Amiodarone is probably the most powerful antiarrhythmic drug out there. However, it has a slew of non-cardiac side effects that we typically have to monitor for very closely. Lung disease, liver disease, thyroid disease, and even nerve disease and muscle disease can occur from the use of amiodarone. It's used on a short-term basis. Usually we try to avoid using it for a very long period of time because these side effects typically start to happen if it's used for a long period of time. You know, there are other drugs that can actually cause dangerous rhythms. So they treat the atrial fibrillation, but also increase the risk of other more sinister rhythms. And those need to be monitored for in a different way. Dronedarone is a very safe drug to use. It's actually the same as amiodarone, but without the iodine moiety. Unfortunately, it's not very effective. So what is the ablation procedure? You know, in order to understand catheter ablation, we really need to kind of understand what triggers atrial fibrillation. And studies have shown that in the vast majority of people with atrial fibrillation, the triggers for atrial fibrillation start in the pulmonary veins. And here on the right, you're looking at an electroanatomical map that's created by moving a multipolar catheter within the left atrium. You're looking at the back of the left atrium, and you're seeing 4 pulmonary veins. Now, these pulmonary veins are normally functioning as conduits of blood from the lungs to the heart. However, they do have sleeves of muscle that can grow into them, and in some people, and most people with atrial fibrillation, these muscle sleeves can set off chaotic electrical activity that can cause the back of the heart to beat very, very chaotically in a very disorganized fashion. If you look at the back of the heart in somebody with atrial fibrillation, it actually looks like a bag of worms. So what you're looking at here is an electroanatomical map created by the multipolar catheter moved throughout the left atrium, and you're seeing these red dots that are lining the interface between the pulmonary veins and the left atrium. And these red dots are ablation lesions performed when we do an AFib ablation. The goal is to isolate these pulmonary veins electrically from the rest of the heart. By preventing electrical activity from escaping the pulmonary veins into the back of the heart, you can effectively eliminate the triggers that cause the back of the heart to fibrillate and allow the normal rhythm to take over. Now, these benefits can take time. We say this because there is some swelling in the back of the heart that can take a while to heal up after an atrial fibrillation ablation procedure. Typically, we give ourselves about 3 months when all the swelling is gone before we can say whether or not an AF ablation has been effective or not. So there are 2 ways to do AF ablation. There is the cryoballoon ablation approach, which is depicted there on the top, and there is radiofrequency energy ablation depicted on the bottom. Now, the cryoballoon is basically a balloon that's deployed into the left atrium. In order to get to the left atrium, you actually have to get access into the right femoral vein. A catheter is deployed into the heart. A needle is then used to cross from the right atrium into the left atrium, and then this balloon is placed into the pulmonary vein. The pulmonary vein is then frozen with the balloon, and what happens is that this freezing will actually cause a scar around the interface between the vein and the atrium. There's 4 veins, so this has to be done 4 different times with the balloon. Now, in the bottom, they're using radiofrequency energy in a point-by-point fashion around the vein. The access into the left atrium is the same way as you would get for the balloon. However, here, the catheter is being moved in a point-by-point fashion. You're heating the tissue in order to form the scar that isolates the pulmonary vein from the rest of the heart. Both approaches are actually equally effective. And with the technology we have now, the recurrence of atrial fibrillation after either is pretty similar. And the durability of these pulmonary vein isolations are also similar between the 2 technologies. So this is basically that electroanatomical map that I had shown you before, but you're actually seeing it in real time, and we're looking around the left atrium and seeing these lesions that are made and how the veins have been isolated. Now, the colors are actually very useful. We use these colors to understand how healthy the left atrium is. Purple is normal voltage, and that tells us that the purple part of this heart is totally normal. The red means that there's no electricity getting in or getting out. And that's kind of what it should look like at the end of a AFib ablation. Once these lesion sets are performed around these veins, there's no more electricity going out and no more electricity going into these veins, and that's how you know that you have had a complete pulmonary vein isolation at the end of the procedure. The catheter inside this heart is a multipolar catheter that is used to create this anatomy. It's also the catheter that we use to confirm that we have entrance, we call entrance and exit block into the pulmonary veins. So how effective? Here we're looking at cryoablation versus drug therapy. And on the x-axis, you're just seeing days after the index procedure. Now, there is a blanking period, like I talked about, the 3 months or 90-day blanking period after the ablation. The reason why we have a blanking period is because of the swelling in the back of the heart and around these lesions. So just imagine you just got knee surgery, right? Knee surgery does take a while until that pain all goes away and you feel better than when you came in. But for the few weeks after your knee surgery, you actually have more pain than when you had before your surgery. It's a similar approach to understanding the effectiveness of AF ablation. There's swelling around these lesions. It takes a few weeks for the swelling to ease up. And while there's swelling there, the back of the heart can be a little jittery. So you can have a little AFib pop up a few days or even a few weeks after the ablation. Typically, we can treat that, and usually we give ourselves 3 months to take another look to understand whether or not this atrial fibrillation is going to continue being a problem. Now, this chart shows you that the efficacy of ablation, and here they're looking at cryo, is much better than for drug therapy. Much, much better, and the curves diverge pretty early on. We're looking at about 70% efficacy from atrial fibrillation without the need for any drug therapy. All right, so thank you so much for your attention. And if you have any other questions, please let us know at the end of the presentation. I would like to add one more thing, just a few more slides. And this is to talk about permanent atrial fibrillation. Once patients are in permanent atrial fibrillation, we typically apply an approach of rate control only. And this is kind of where the role of pacemakers comes in. Pacemakers can be used, and patients with permanent atrial fibrillation are usually the prime candidates. It's diagnosed when all attempts at rhythm control have failed, and the goal of the therapy really is just to control the heart rate. Medications such as beta blockers or calcium channel blockers are medicines that can slow down the heart rate in general, and we try to control symptoms this way. However, in patients with permanent atrial fibrillation, sometimes their heart rates can get too slow. And sometimes their heart rate's either too fast or too slow, and the medicines are not doing very much for them, or just causing their heart rate to get too slow when it's not fast. So the pacemaker can come in to help regulate the heart rate and allow these patients to have better control of their symptoms. And typically, when we put in a pacemaker, we do couple it with a special type of ablation called the AV nodal ablation. Now, the AV nodal ablation is a much more simple procedure than the AFib ablation because we ablate one discrete part of the heart. And what you're looking at here is basically a catheter that's placed from the right femoral vein and guided to the middle of the heart on the right side, the junction between the top and the bottom. And we do this type of ablation after a pacemaker has already been placed inside the heart. Once the pacemaker has been placed inside the heart, we then deploy this ablation catheter to the junction between the top and the bottom and cauterize it. And by cauterizing it with radiofrequency energy, we cut off the electrical signals to the bottom of the heart and allow the pacemaker to take over complete control. And we can actually control the heart rate by programming the pacemaker non-invasively after this procedure. It is an end-all, be-all procedure, and patients do become dependent on their pacemaker. However, pacemakers are quite reliable these days. These patients are known to have 6 sinus syndrome as well. And these are the patients who typically end up needing pacemakers because their heart rates are too erratic and difficult to control. This is an example of sick sinus syndrome. What you're seeing here is basically periods of atrial fibrillation separated by a flat line. So you try to give them the meds to slow down their heart rate, but then they flatline for a couple of seconds, then they come back. There is really no way to treat this patient's AFib without a pacemaker. There are two types of pacemakers. I don't want to delve too deeply into how these pacemakers works or how these pacemakers work or the technology behind them, but I do want to discuss the different ways we can implant these devices. Transvenous pacemakers are the oldest pacemakers out there. They've been around for decades, and they're implanted in a traditional way by doing surgery on the chest and guiding cables into the veins that go to the right heart. These cables can be guided to the heart and can actually be attached to the heart using tiny little screws on the end of the cables. And the generator is then attached to the cables and tucked inside a pocket beneath the skin on the chest. So there is minor surgery involved in placing these pacemakers. So as you can see, you have a cable that's placed into the vein, guided down into the heart. The back of the cable is then attached to the generator. The generator is then placed under the skin in a pocket, and the pocket is closed surgically. Now, the problem with those transvenous pacemakers is that they can get infected. They can also cause problems with the valves in the heart. As we're trying to get access into the vein, the lungs can actually be punctured. These are not common complications. They're pretty rare. But when they do happen, they're actually considered to be pretty major and can cause some significant morbidity. The leadless pacemaker has been developed for patients with permanent atrial fibrillation, and this is a great option for people that don't need any pacing in the top chamber. The leadless pacemaker can be implanted by accessing the right femoral vein and using a catheter, which is a long straw-like device. This device, which is the size of a large pill, can be guided to the heart under live X-ray or fluoroscopy. And on the end of this pacemaker device, there are tines that could be used to help this device lodge into the heart. Once we are happy with the position of the pacemaker and we're happy that it's lodged in appropriately, this device can actually be released into the heart, the catheter taken out, and there's no cable, there's no surgery. The risk of infection is almost zero, and there is no risk of puncturing the lung. Great option for people who are not great candidates for the surgery involved for implanting a traditional transvenous pacemaker. It's also a great option for patients who have had an infection with a transvenous pacemaker in the past. And like I said, patients who don't need atrial pacing are great candidates for this too, because this device can only pace one chamber, the bottom chamber. So it is the size of a large pill. Like I said, no surgical scars, and it is a great option for patients who have permanent atrial fibrillation. And the risk profile is slightly better in certain aspects than a traditional transvenous pacemaker. So thank you so much, and I'll leave you with Dr. Srini to talk about WATCHMAN for stroke prophylaxis.
All right, folks, so I'm going to wrap it up tonight and talk about stroke and blood thinning medications and what we can do if you can't take a blood thinning medication. So think of your heart like a house, and when you have a house, you're going to have people working on it. So you've tonight heard from two of the electricians, and now you're going to hear from the plumber. So from my angle, how I treat atrial fibrillation is not by the ablation method, but rather, in addition to what they do, is also talking about the risk of AFib and causing stroke and what we can do to kind of reduce that risk of stroke if you cannot take a blood thinner. So we've already talked about tonight about AFib. It's irregular heart rhythm. The top parts of the heart, the atria, don't communicate electrically with the bottom. That's a very basic plumber way of looking at it. It results in symptoms of shortness of breath, lightheadedness, and palpitations like we previously discussed. So again, we went through the causes, and for the sake of time, I'm not going to just reiterate all of them, but as you can see here, big ones, heart attacks, high blood pressure, and exposure to tobacco or alcohol. Obviously, sleep apnea is another big issue as well. So to diagnose it, you just can't say you feel an extra beat here or there and say you have AFib. That could be a lot of other reasons causing that. You need an EKG or an ECG. So keep that in mind, because you can have a lot of other rhythms that simulate an extra beat every now and then that is not AFib. So normally when someone comes to me with atrial fibrillation that's been documented and we know that they had it or have it, we utilize medications to control the heart rate. Hopefully, just by doing that, they may feel better. Anti-arrhythmic medications, which are drugs that keep you into normal rhythm, are also things we can utilize. If we can't use those medications successfully, sometimes we give you a little bit of energy, called a cardioversion, where we shock you back into normal rhythm. You don't feel it, you're sedated, so don't worry about that, but you definitely get shocked into normal rhythm, hopefully. And if that doesn't work, well, then you go to see my colleagues over here for potential ablation to get rid of the AFib. But see, one thing a lot of people don't really understand about AFib, that even if you have an ablation procedure to get rid of it, there's always a risk it can come back. So even patients that get an ablation oftentimes stay on a blood thinner. So when patients see me and say, I want an ablation because I don't want to be on a blood thinner, even though they don't have symptoms of AFib, don't really understand that AFib is something like a boomerang. It can come back. Even though with successful ablations, there's always a chance it may reoccur. Hence, being on a blood thinner is mandatory for a number of these patients. So that blood thinning is utilized secondary to the fact that when AFib basically quivers in the top chambers, it can cause clot to develop, and that clot can break off and cause strokes. So blood thinners are mandatory in patients who have higher risk factors for stroke, in patients with AFib. So again, if you have AFib, your physician will sit with you and say, let's look at your risk profile of what may cause you to be a higher risk for stroke, and let's talk about being on a blood thinner. Blood thinners work great. Things like Coumadin or warfarin, which are basically the medication that we utilize for decades, works great, but you got to keep it regulated. There are newer medications like the Xareltos or the Eliquis. Those medications you see commercials for work very well, but a lot of times insurance will charge an arm and a leg to utilize it. So first and foremost, we've got to talk about AFib and stroke. So we do know that the higher stroke risk for older patients than those with prior stroke. 15 to 20% of all strokes are related to AFib. And AFib can result in a greater disability than compared to non-AFib related strokes. So again, we know strokes can be debilitating. Unfortunately, strokes are not like heart attacks. Heart attacks generally reappear in the same type of pattern. People have chest pain, maybe abdominal pain, jaw pain, arm pain. Strokes can be a number of things, from movement issues, from drooping of the face, from the fact that speech can be impaired, from cognitive defects. There's a lot of different ways strokes can present. So the guidelines have stated very strictly in the ACC and HA about how we should go about treating patients. So we are very much moving into a direction where even the lowest risk patients are being told, hey, maybe instead of an aspirin, you should probably think of going on a more potent blood thinner. But the problem with being on a blood thinner, you have the risk of bleeding. It's kind of a double-edged sword. With one side of the sword, you can basically get rid of the stroke from a clot going somewhere, but the other side of the sword, if you're on a blood thinner, there's a higher risk of bleeding. And this slide just shows you how a brain bleed can happen spontaneously just by taking a blood thinner. So we have to utilize in medicine risk scores. So how do we have patients that have a higher risk of bleeding or a higher risk of stroke? Well, we have to kind of put them against each other to figure out who would benefit from being on a blood thinner. And we oftentimes use this thing called the CHADS-VAS score. And as you can see there on the left, what it really breaks down to is the letters are representative of certain conditions, whether it be heart failure, high blood pressure, your age, having diabetes, prior stroke, vascular disease, or your gender, being female, giving a point for being higher risk. We utilize that score, and on the right, you can see how we can calculate your yearly stroke risk. This is another way to utilize a score, but not for stroke, but rather bleeding. So when we look at this score, which is called the HAS-BLED score, we can calculate out what is the likelihood of a patient having a major bleed with their score going up higher and higher. So with this, we've utilized how we can predict sometimes how patients would say, well, I can take the blood thinner, but I really don't want to have the bleed. How do you really know what my chances are? Now, no one's perfect, but these scores give us an idea of who's a good candidate to be on lifelong blood thinners versus who is not. So we know the most popular medication, or most widely used, is warfarin, or also known as Coumadin. This is a medication which is basically administered, it's very cheap, it's orally administered, it can be reversed if it's too high. The downside with this medication is it limits what you can eat. So green leafy vegetables, not a good thing to do when you're actually on this medication. Additionally, other medications can interfere with how this medication works. And as you can see there on the right, just because it's a little high doesn't mean it's a little good. If it's a little high, you have a 44% chance of bleeding events while on the medication. So if you say, well, I don't want that, I'm going to take a little less today, maybe I'll just stray a little bit less than 2.0, and guess what happens there? Nearly 50% of all events on people with Coumadin happen because they aren't on the right dose. They're too low, so hence the clot can develop and form and go to the brain. So what's the other option? Like we mentioned before, those medications you see commercials for now, the Xareltos, the Eliquis, these medications are indicated for treating people with AFib. There's no dietary restrictions, and it's a fixed dose. So it is something that people would say, okay, maybe it's better than taking the alternative. The problem is the people have a compliance issue. Patients don't want to be on potent blood thinning medications long term. Additionally, the cost of these medications are not cheap. There's no generic varieties of these medications at this time. So people have a tough time staying compliant. I can't tell you how many patients of mine have come in and said, you know what, I just want to cut it in half or take it once a day instead of twice a day, just to save some on the pills, save some of the money. And they're like, well, if I don't take the full dose, can I get some benefit? The answer is no. The medication is made for a certain level of your kidney function, of course, your age, your weight. You have to take the prescribed dose. So a lot of patients just don't want to, and they feel like, hey, you know, it's more of a pain to stay on the regimen than obviously take it at all. So adherence and major bleed rates are actually similar to patients on Coumadin. So even though with Coumadin you have to regulate your levels and with other newer medications you don't, we are still seeing major bleeding occurring with the newer medications as well. So again, we know AFib is a growing problem associated with greater morbidity and mortality. We know the current treatments to prevent stroke include warfarin or the newer medications like Xarelto and Eliquis, but many patients stop taking these medications, or they have bleeds on the medications, or their insurance won't cover the newer medications. So we know that the older we all get, the bleeding risks go up. It's just a natural process of the human body. We do notice this happens, and as older you get, the bleeding risks obviously start compounding. So again, this slide, or you can see on the right there, what you're seeing, that little ball, that rounded area, that's the appendage, and that area that's in it is a clot sitting there in the appendage. So we have found out through many, many post-mortem studies, and obviously with the imaging we have in the last 50 years, that a majority of the blood clots that come from AFib, over 90% of them, originate in something called the left atrial appendage, which is a little sac sitting in the left atrium. What is a sac for? Maybe millions of years ago it had a purpose, like our appendix. But right now, there's not much functionality to the left atrial appendage. And how do we know this? Because surgeons, when they perform open heart surgery, will oftentimes just clip the appendage to prevent any clot from developing there if the patient develops AFib. And we've seen now from decades of usage of this that patients don't suffer. So we felt, hey, this is a great novel idea that the surgeons have been showing us for a long time. So what happens from there? Well, instead of opening someone's chest to ligate the appendage, a device came about in the last 15 years, and this is called the WATCHMAN. It's a one-time implant that does not need to be replaced. It's performed in a cardiac cath lab and is not an open heart procedure. It's a catheter procedure, and I'll show you a video of how exactly it's deployed. Usually it takes about an hour, and patients usually stay in the hospital for about a day. So with that, I'm going to click out of here, and I'm going to go ahead and I'm going to show you what that video looks like. So from this, we utilize the right common femoral vein, which is in the leg groin region, and go up with the catheter through the inferior vena cava to the heart. We then make a puncture from the right side to the left side of the heart. You do not feel this. Patients do not feel this part of the process. A wire is then placed into the atrium and replaced with what we call the WATCHMAN sheath. We then place a pigtail catheter into the left atrial appendage. And these are just different names for the appendages: the windsock, broccoli, chicken wing, very, very fancy names apparently. We put the pigtail catheter into the appendage and then measure where the distance from the back of the appendage is with some contrast. We kind of elucidate what the appendage looks like. Once we have the correct size that we think, we then pull the pigtail back and then place the WATCHMAN Flex device. The device is a ball, and we literally push this ball in. And if we don't like where it's sitting, we then retrieve it and then push the ball back in. And it's so atraumatic that it doesn't bother the appendage wall. At this point, we then redeploy the device. And if we like where it sits, we then go through a fixed criteria to look at the position. We then look at the anchor, which means we basically do something called a tug test to pull it back. We then look at the size, and we compare it to a chart that we have readily available. And then finally, we look at seal to make sure there is no contrast or flow around the device, which would tell us there's any leaks. And if we're happy with that, we then deploy the device. And there's anchors on the device which go into the wall of the appendage and hold it in place. And again, with this type of exposure on the face of the device, we're seeing less clot development on this device. This is a newer device that's been out for about a year and a half. We've been utilizing it here at BCH regularly, and it's had excellent results. So again, just looking at this, on the left, we were looking at the device that we used to utilize previously. The device on the right is called the Flex, which is the one we currently use. I was actually utilizing this WATCHMAN device for over 7 years. And actually in the state of Colorado, of all the programs performing this procedure, I'm actually the only proctor for this company that utilizes this device, which means I can go around the nation and training people in this device, just to give you a background of how many I've done. And the newer device is fantastic compared to what we used to utilize. Much safer and a much more reliable deployment. How do we know all this? Rather than going into the ad nauseum of all the studies that have been done, I just wanted to show you this is one of the most studied medical devices on the market. This is important because I would hate to have this device ever placed in someone and say, well, there's been a couple of hundred patients and that's all we have. There's thousands of patients that have had this device deployed successfully, and we've learned a lot from the last 10 years of these trials that have been done. We know, though, at this point in time, if you cannot tolerate a potent blood thinning medication and you have AFib, the WATCHMAN is a suitable alternative. Again, I want to repeat that statement because I'm sure I'll be getting questions about it later. If you have AFib, and you cannot take a blood thinning medication because of whatever reason, whether it be bleeding, fall risks, or some other issue associated with the blood thinning medications, the WATCHMAN becomes suitable. The WATCHMAN is not for patients who say, I can take the blood thinner, I just don't want to. That's not a good answer. If you can take the blood thinner and you can afford it and you don't have side effects from it, you need to stay on it. And that's for patients with atrial fibrillation. Again, these are things that, again, we'll repeat, but the main issue is I have a lot of people coming to see me who say, I saw the ad, I saw the commercial, I saw your talk, I don't want to take a blood thinner, get me the WATCHMAN. And I will tell them flat out, you're not getting it unless you have a medically indicated reason not to be on a blood thinner. The big issues with WATCHMAN, of course, we reduce major bleeding because we're getting you off the blood thinner. 72% reduction in major bleeding events reduction with being on the WATCHMAN. And again, we know that with WATCHMAN compared to no therapy, it's better than nothing at all. I have patients that come see me and say, well, I don't want anything in my body. I don't want you to put that thing in me, but I don't want to take a blood thinner either. That is crazy. If you can be on a blood thinner, take it. If you can't take the blood thinner, get the WATCHMAN. But don't ever say to someone, well, I have AFib, and I'm just going to roll the dice and take my chances. Because that's something we cannot in medicine predict completely accurately. And I've told patients that. I don't have the crystal ball. So if you tell me I don't want to be on a blood thinner, but I don't want a WATCHMAN, and I'm going to take my chances, you literally are playing Russian roulette, and it's a dangerous game. So I would tell you, think about it twice if you are against taking a blood thinner. So again, most studied device that's in the market right now, which is amazing and showing very positive results for the right patient population. And again, that's what I want to mention. If you can take a blood thinner, you take it. If you can't take a blood thinner, you talk to your physicians and say, I have AFib, I can't take a blood thinner, am I a WATCHMAN candidate? And then we'll move forward and have the discussion. But again, no one should ever feel that they can just take the device or the medication and say, you know what, this is so much better than this. We need to have a discussion with you. That's why seeing your physician about these issues is critical prior to making any decision about any procedure. And with that, I'm going to say, I'm just going to go through here real quick. Thank you for your time, and we're going to move forward with our questions period at this point. Thank you.
Thank you so much for that presentation. That was invaluable information, and we do have a few questions we've collected. We'll ask our viewers to go ahead and submit any further questions that they have, but we do have a few lined up here. First of all, let's see. Well, we have a lot of questions about insurance and payments and things like that. We'll address that. Does insurance cover the WATCHMAN device and other procedures and ablation?
Well, from the WATCHMAN standpoint, yes, insurance definitely covers. Medicare, private insurance will cover it as long as the documentation from your physician is in the notes stating why you need to get the device.
Great, great. And for other procedures, they're generally covered?
Yes, often insurance with atrial fibrillation, in general, most insurances require that a person has tried and failed at least one medication to control the AFib before they'll approve the procedure. We may be moving away from that, but at this point in time, we almost always will try at least one medicine, and if the person can't take that because of side effects or lack of efficacy, then we can move forward with offering and scheduling ablation, and then insurance will cover it.
Perfect. This guest asked, I've had AFib and take Eliquis. I'm having dermatology issues soon. Excuse me. She's having dermatological, there we go, surgery soon. How long before the dermatology procedure should I stop the Eliquis?
I would recommend discussing that with her physician. A lot of that depends on her overall risk for stroke. Patients with AFib sometimes can stop it for several days without any issues before elective procedures. And sometimes if there's a very high risk of stroke, we will want them to stop it, but at the same time take a different type of blood thinner, either IV or under the skin, while they're off of it.
And typically, a surgeon, a non-heart doctor, will contact us and say, I have this patient, what I'd like for them, for their blood thinner, would be, say, to hold it for a couple days. From a cardiology and stroke standpoint, do you think that's okay? And then we'll say yes or no or give alternate advice. And so we do those kinds of conversations as a team every day.
Yeah. Actually, the most important thing to understand is the surgeon is the person that understands what the risk of bleeding is for their procedure. So typically when they contact us, they ask us for a number of days off the blood thinner, and then we determine if it's safe for the patient to be off for those days. But we aren't the doctors that determine the number of days that they need to be off. It's the surgeon that needs to make that determination.
Perfect. Let's see here. Let's get back to this one. After successful the WATCHMAN procedure, do you ever need to restart DOAC?
So after a WATCHMAN procedure, the only time we've restarted having patients take a blood thinning medication is if there is some other issue that usually arises. Now, there are patients who get blood clots in their legs maybe years after a procedure, in the sense that it has nothing to do with the WATCHMAN, but they will need to be treated for that DVT or a blood clot somewhere else. So of course, if there's a secondary issue that may arise after the WATCHMAN, there may be a need to go back on the blood thinner. But of course, for the WATCHMAN per se, if the device is in place and we check it at 45 days after the procedure to make sure that it's secure and in place, generally we've had an excellent rate, I would say well over 99% of patients coming off their permanent blood thinners after the procedure.
If I might, perhaps you want to address what blood thinners people are on and for how long, starting day of the procedure.
Yeah, so normally for the WATCHMAN procedure, now there's been new indications where they used to have to stay on a potent blood thinner like Coumadin, Eliquis, or Xarelto for 45 days after the procedure. It has now changed, and patients can actually take a baby aspirin and something called clopidogrel or Plavix, which is still a blood thinner but less intense than the ones I just mentioned, for 45 days. And this has opened the door for a lot more patients who really are hesitant to take the potent blood thinners at all to be getting this therapy and then being on this, we call it DAPT, which is dual antiplatelet therapy, which is the baby aspirin and clopidogrel or Plavix for 45 days.
Perfect. About sleep apnea. Obstructive sleep apnea has been mentioned twice as a risk factor. What about central sleep apnea?
I would say yes, that is also a risk factor, because the oxygen drop at night is one of the primary reasons why people go into atrial fibrillation. The obstructive sleep apnea also adds another layer to that, but they both drop their oxygen at night, and those low oxygen levels can increase the pressure on the right side of the heart and increase the risk for AFib.
This guest asks, I hear you on a plant-based diet, but are some meats better than others in small portions?
That's a great question, and yes, processed meats are the worst for almost every outcome. So processed meats, by which I mean, and don't shoot the messenger, but things like bacon or lunch meats, deli meats, things that are processed like that, they carry an increased risk of atrial fibrillation, but also raise blood pressure, contribute to heart failure, raise the cholesterol. And so they're associated with a wide variety of adverse health outcomes. And so things, animal proteins like fish protein are much less associated with those outcomes.
How high is the risk of stroke with a person with AFib in percentage terms? I guess.
So, like Dr. Iyengar talked about, he presented this stroke score that we do, and it has a very long name, the CHADS 2 VASC score. And that is what we all use to decide whether or not we would advise someone to be on a blood thinner. That takes into account multiple conditions, including your age, your gender, whether or not you have high blood pressure, whether or not you have blocked heart arteries, whether or not you've previously had a stroke. And we use that in every single person we see, and most of us can kind of mentally calculate that in about 15 seconds. And that correlates with someone's percentage per year risk of stroke. For example, if someone's score on that is 4, and that might be someone who is 75 years old, that's 2 points. A woman, that's another point, who has high blood pressure. That would correlate by a lot of data that's been gathered over many years to a little over a 4% per year risk of having a stroke. So that's not 4% every day, it's like over the course of a year, 4% risk. And a blood thinner like Eliquis or Xarelto will greatly reduce that chance of stroke.
And it's important to understand too, because even if you look at it and say 4%, that's not that bad, I'll take my chances. Well, if it happens to you, it's 100%. So that's why it's very, very important to understand that even the guidelines are stressing even lower risk patients at this time may need to benefit or may benefit from being on these blood thinning medications.
That's right.
If you have AFib, can you modify lifestyle and retest? Will lifestyle reverse AFib once it's occurring?
Yeah, so in AFib in its very earliest stages, where it's very episodic, say someone's had their first episode of atrial fibrillation, or they've had an episode and then don't have another one for 5 years, or they've had 2 episodes of AFib, both of which happened after some trigger like an infection or a night out with several glasses of wine. That's the ideal time to intervene on lifestyle, and that can prevent people from having more AFib for long periods of time. But even when AFib is more advanced, there is evidence that lifestyle measures to reduce weight, lower the blood pressure, can both reduce the risk of stroke from AFib and can get it to stop its natural progression from episodic to just lasting AFib. So it's worth it at any stage and probably most value at its early stages.
So, Dr. Iyengar, I think this was a portion of your program section of the lecture. What does SOB mean regarding when you said AFib results in symptoms of SOB, lightheadedness, and palpitations?
Clearly it means no, I'm kidding, not that far. No, it means shortness of breath is what it means. So SOB it means shortness of breath.
Perfect. Thank you. Yeah, good. At what point, what frequency of episodic AFib occurrence is non-lifestyle intervention recommended? So at what point is non-lifestyle intervention recommended?
Well, I think that typically comes in if lifestyle intervention is really not working. So we always start with lifestyle intervention, but if we see that the patient is doing everything they can, exercising, they're losing weight, they're very compliant with their CPAP if they have sleep apnea and they're taking their medications, then quickly we will move to either using medicines to convert the AFib or even fast track to an ablation depending on how severe the symptoms are.
Right, I think the question was a little clarified, what frequency of episodes of AFib?
That's very individualized from person to person. Some people may have brief episodes of AFib and they last for a few minutes here and there, they barely notice them, they take a blood thinner if it's indicated, and they don't really need to be on more aggressive medications or consider an ablation. But on the other hand, some people, feel AFib every time they have it. It goes very fast. They have to stop in their tracks and can't do their usual activities. They need to go to the emergency room to get out of AFib. I usually tell my patients, if you as an individual are at the point where this is interfering with your life, then I would recommend we take action. And also, lifestyle medicines and lifestyle interventions and medications for AFib can be done simultaneously.
All right, thank you. Can you explain again, I think this was in your section, Dr. Iyengar, can you explain again what you meant by, quote, 90% of clots formed in LA come from LAA?
Correct. So basically in atrial fibrillation, we have seen in multiple studies and postmortems and things of that nature that why do people have strokes in AFib? Well, somewhere the clot has to originate from somewhere, and the vast majority, over 90% of the time in AFib, the clot comes from the left atrial appendage, which is located in the left atrium, and hence why we've developed that WATCHMAN procedure to plug it off, because that's where we see most of the clot develop in patients with AFib.
What is the WATCHMAN device made of? And how does one know if they might have an adverse reaction to that material?
That's a great question, actually, because I do ask all patients prior to putting the device in, have they had any metal allergies or nickel allergies, really? Because it's a nitinol frame, which is nickel titanium. And nickel seems to be the most common metal allergy that we've encountered. And oftentimes patients will say, oh, I've had earrings before, no problems. And people have hip replacements, no issues. Metal is something that, again, if you've had an allergy, especially at the age group where you're utilizing the WATCHMAN in, generally it's been seen at an earlier age. But again, it is something that is worth noting. If there's any question that you're worried about having any of these allergies, maybe you don't wear earrings, maybe you've never had any metal in you, I would say let's get an allergist involved first and get an allergy test, because it's always better to find out early that you're allergic to something than having it in your body and then finding out.
No one has mentioned propafanone. I am taking Eliquis.
It's propafenone.
Propafenone. Is this a good combination with Eliquis?
Propafenone and Eliquis can be taken together safely. Propafenone is one of the antiarrhythmic drugs that is available to us to help control and convert AFib and keep patients who have AFib in normal sinus rhythm.
Wonderful. What are the physical limitations after any of the invasive procedures?
For atrial fibrillation ablation, we now perform these very efficiently. They've gotten more efficient and safer over the couple of decades since the procedure was invented. I actually don't know how when we finish, we take those tubes out and we can hold pressure on them and then have people lie flat for a while. Or we can close the little IV sites where we've put the access catheters in the leg veins. I use a device that closes up, puts a tiny little stitch in the 3 IV sites, and people can sit up right away and walk around within 2 hours and even go home the same day in most cases. And then I limit activity, vigorous activity, for better part of a week after that.
And it's very similar for the WATCHMAN procedure as well. Same thing, we go through the vein, which is a lot more forgiving than going through the artery, because the artery is a much more higher pressure system. So for this procedure, people oftentimes have an ability to get up and move around a couple of hours after the procedure. We don't want them to lift heavy things like 30 pounds or heavier for the first few days. And it's really, honestly, at this point, they do recover quite quickly. And after about 5 days seeing us in the office, usually they're doing back to normal.
Awesome. We have couple of more questions here. I'm just going to ask them from the podium. So this guy says, I have paroxysmal
Paroxysmal.
AFib and walk 8 to 12 hours a week. Should I decrease my walking hours?
I would say for walking, it's not limited. It's more, and that does not increase AFib at all. It's more very vigorous exercise, like cycling up a hill, like running a marathon, like Nordic skiing. Those kinds of exercise can increase atrial fibrillation, but walking does not at all.
Great. And we have one last question, unless we get a few more here in from our viewers. So, is there a duration of an AFib episode when stroke becomes significantly more elevated? An hour, a day?
Typically, we do have to take a look. If somebody's been in AFib for more than 24 to 48 hours, and we are looking to try to convert that AFib to normal rhythm with a cardioversion, then we do take a look with an ultrasound probe through the food pipe to make sure there's no clot inside the left atrial appendage. Typically, 24 to 48 hours is what we usually cite as the time that it takes for a clot to start forming. However, that's not written in stone, to be totally honest. I think when you look at the risk factors for stroke from our CHADS VAS2 calculator, that can change how quickly a clot can form.
And so we don't say this person only has very brief episodes of stroke, of atrial fibrillation, but if their CHADS-2 VAS score is 2 or more, even if they're short-lived episodes, we still recommend a blood thinner because they're at risk of stroke without one.
Excellent. Are there age limits for ablation or WATCHMAN? Are there any age limitations for these procedures?
So for WATCHMAN itself, there isn't necessarily age limits, but again, it has to become a realistic aspect of what is the person's quality of life at that time and what are the indications for the WATCHMAN procedure. So if someone is bedridden, they're not really a fall risk, so that's not really an indication to say that's something they should be getting. Now, it really comes down to, again, what are the risk factors for the procedure to begin with? Age is not definitively by any means a cutoff because we see plenty of patients in their 80s and 90s who have strokes because they've stopped their blood thinners because they said, I'm too old to take one of these, what are the chances? And they end up in the ER. So I don't use age as a criteria as much as I use with the quality of life of the patient or the status of the patient at that given time.
And I would probably give a very similar answer for ablation. I think there are certain people who may be too old or their current quality of life is not great, and doing an invasive procedure like a catheter ablation may only worsen their quality of life, even though we've been able to control the AFib. Personally, I've ablated people as young as their early 20s, not because they're good candidates, but because we've tried drugs and the AFib has been extremely aggressive, have impaired their quality of life significantly, and the ablation has been able to liberate them from a lifelong antiarrhythmic drug therapy that for somebody who is young could be very, very bad for their quality of life.
And that said, I mean, someone has many medical conditions, who's very elderly, say in their late 80s or 90s, the risks of any invasive procedure increase at that point. So an AFib ablation, it would be pretty uncommon to perform that in someone in their late 80s or 90s due to increased risk from the procedure as well.
Are there any side effects with the WATCHMAN? Are there any downsides?
Well, of course, it's an invasive procedure, so there's no doubt that before I perform any procedure, we have to sit down and talk about the risks and rewards of performing something that's going to go in your vein, into your heart, and there's going to be issues of, well, we put this device in, it's a permanent device. we have to make sure that, number one, that it's secure and that the patient's secure with that in their heart. And number two, what are the risks of the procedure itself? Like we just mentioned, it's vascular, it's in the heart. So there's always going to be the potential of stroke, infection, bleeding, and I bring all of these out because it's important to talk about it. And if a patient says any of those that I just mentioned are too scary, well, then we go back on the blood thinner. Because again, at the end of the day, it's important to have a discussion about the risk rewards about anything invasive, because there's no such procedure that is 100% safe. Otherwise, it's not a procedure.
Correct, correct. All right, we have one last question. I'm going to try to read it. It's a little abbreviated, and it might be a little too specific, but let's see, since we have another minute or two. All right, this guest says he or she has had 3 ablations last September for a flutter and AFib, then AFib after 3.5 weeks, then AFib again, and then amiodarone for 2 months.
Amiodarone.
What percentage of patients will fully recover with all that?
So I think what they're describing is somebody who has gone probably from paroxysmal AFib, AFib that is present only sometimes, to AFib that is present all or most of the time, persistent. Patients with persistent AFib are divided into 2 types. There's your regular persistent AFib, where you have AFib for at least a week, and then there's long-standing persistent AFib, where you have AFib for continuously more than a year. Those patients tend to not do as well with catheter ablation, especially patients with long-standing persistent AFib. So the whole point is the longer you're in AFib, the less likely you're going to respond. The more likely you might need multiple ablations in combination with antiarrhythmic drug therapy to keep you in normal rhythm. That's why we emphasize the importance of early intervention to try to get the AFib when it's still in the paroxysmal or present sometimes phase versus waiting until the AFib is there all the time. And this, I'd like to actually add just one thing, is that sometimes I do meet patients who are early on in their suffering with AFib, and they will a lot of times tell me, you know what, doc, let's just wait this out. Let's see how I do in a few months. Let's reevaluate in the year. And during this period of time, I'll try to do some lifestyle interventions. That does concern me a little, because we do know that without aggressively either converting it to normal rhythm, trying medicines in conjunction with the lifestyle interventions, sometimes we fall behind the 8 ball and we're playing catch up a year later when they've already gone into persistent AFib, and then all of our interventions and ablations eventually become futile. So early intervention is very important.